Dr. Dietrich is our next speaker, and she is the medical director for the paramedic program here at RAN. She's also attending at Children's Hospital. She's an educator and well-known throughout the community. She's going to be discussing to transport or not to transport. So thank you.
I don't know if I wanted to hit that. Can you guys see the slides? Can you see them okay? My lecture today is going to be on should I stay or should I go? And the reason that I picked this topic is because I think in this day and age, we're increasingly faced with choices that must be made regarding whether we are going to take a patient to the hospital or whether in some situations it is better to leave them based on what is going on. I think, let's make sure you can see this. Let's play doctor, you can be my malpractice lawyer. Recognizing risk. So my focus of my lecture today is going to be talking about pediatric patients and some of their unique characteristics and who you should not leave at the scene. So I'm going to kind of go through some different categories and hopefully give you some diversity of education in pediatrics. And of course, afterwards, I'll be happy to answer any questions. So originally, the question was, who are we going to transport? And originally, if you go back and you talk to everybody about EMS systems, we were constructed for specific reasons. So there was the heart mobile that was looking specifically at can we improve outcome for cardiac patients. Then there was the trauma system that got set up to look specifically at how can we improve outcomes for transport patients. So originally we were targeted at critical areas that needed to be moved to definitive care and needed to be moved rapidly. As the system expanded, it became clear that over the last, I'd say 5 years, a lot of people are now using the EMS system for convenience versus using for our limited resources. And all of you know at 4 a.m. in the morning when you get called for the fever for 1 hour, it's just like you sit there and go, oh my goodness, and then you go as quick as you can to make sure you're available for the next person who may be having a heart attack who sincerely needs your resources. And there also becomes the issue of financial solvency because we really have to have our system set up so that we get to the critically ill people, injured people, such as Mary, who truly need all of us working together to get the best outcome possible versus some of the other things that maybe we could do in a different way to make it less expensive. So there's my, the original, every situation in ER and on this show, I'm trying to remember, it was Squad 51 or something like that. Every situation was always a critical, life-threatening emergency. I told them on ER, I want one of my shifts to go the way that their shifts go. So I'm going to talk about some high-risk pediatric patients, and I kind of want to get them grouped into categories. And so this is to help you identify kids that really, really should be given a second over or a very careful assessment before you decide not to transport them. There's the children less than 28 days of age. And I will tell you from my personal experience and what I tell my medics is if they're less than 28 days of age, I don't care if their mom says they're farting the wrong way, please just bring them into the hospital and we'll take a look at them and we'll reassess things. And we're going to talk about why our feelings are so specific in that age group. We have kids that can have benign symptoms and you may think to yourself, oh, they've just thrown up once or twice. But because of underlying disease processes that they have, they can't even throw up once or twice without being in a very different situation than a normal, healthy child. My favorite category, because this is always falls into something that as a pediatrician I find very challenging, is the problem is actually benign unless someone lies to you and you're not getting the whole story. You know, the dude who brought the kid in and he was innocently not there and I don't know how the gun got shot and so it's benign unless they're not telling you the whole story. Recognition of new diagnosis, and I have to tell you, I am so impressed with the pre-hospital providers in our area because routinely when they could have left people, they'll say, you know what, that fruity breath, I really think it's a new diabetic. I'm really concerned, so I brought him in to see, if there was something else going on. And then the two categories that I spend my life with that I absolutely love our children with pre-existing conditions that we manage at Children's Hospital, and our special needs children. So what could possibly go wrong in a less than 28-day-old? Well, like I always tell my first month residents, everything could go wrong in less than a 1-month-old. And if you think about it, there's very major areas that are affected. Their immune system, so they are immunosuppressed by definition. There's a cardiac transition, and I have to think you can't possibly not believe there is a God when you look at the transition from fetal circulation to maternal circulation and see how it happens over a 2-hour period. It's just an amazing physiologic miracle. Endocrine transition, when they're inside the mom's hormones are there, she supplements things. When the child comes out, they have to make their own. Metabolic abnormalities, again, mom's blood filters everything when they're inside the mom. When they come out, there's a transition where they have to have their body process everything themselves. And that's when we see the genetic defects and some of the genetic abnormalities that can present. And then we have my least favorite, and all of you know during January, February, and March, the blue spell stopped breathing, where it's really hard sometimes to distinguish between the scared first-time parent and a child with a very serious medical condition. So what am I talking about when I talk about immunosuppressed? When they are in mom's tummy, they have a filter system. All of the antibodies that the mother has built up in her bloodstream pass over to the baby. So for the first 3 months, my children never even got a sniffle because I do peds emergency medicine. I have the strongest immune system in the history of mankind. Unfortunately, as they come out during that first week, it starts to drop. During the second week, it drops even further. They have to now start to make their own antibodies. There are bacteria that they are exposed to as they are delivered. The main ones are group B strep and E. coli. As the baby comes out, they are exposed to these bacteria if they are present. The problem is the baby can't say, I've got a really bad fever, my head hurts, and I'm not feeling well. What can happen is these presentations can be very subtle. The last one I saw was a child that mom's a CICU nurse, so they drove 3 hours to get to us. Child had had 1 hour fever, 26 days old, and we pronounced the child dead 3 hours after arrival in the emergency department. And it was an overwhelming sepsis, the saddest thing you've ever seen, but these kids can get sick first. So if the mother says the child has a fever, are you going to leave them or are you going to bring them? Bring them. She says he's cold, you bring him. She says he's not feeding right, you bring him. She says he's not breathing right, don't care, bring him. And to be honest with you, if they have a fever, they're cold, they're not feeding, we do a complete septic workup, start antibiotics, and admit 100% of those children. So we don't even have bravery when it comes to this age group. And after having watched a couple of these kids get so sick, and I actually had a child that came in with like 1 hour fever that we did everything, and the kid grew bacteria from their blood culture, and the kid went home after 4 days. It's just you feel like you can really make a difference with this process. Cardiac transition. I will tell you, it is amazing what happens as the child comes out from the maternal circulation to their own circulation. The problem is that during this transition, a lot of things have to go right. There's something called a PDA that has to close off. The mother's circulation will be pulled away. The baby's circulation has to start filtering through the lungs. That's why those first 2 deep breaths, that's why pediatricians kind of smack the heels and say, scream louder, scream louder, scream louder. Pops the lungs open, lungs start working, pump the blood through the heart, and everything should go the right way, unless the heart wasn't built right to start with. If we know ahead of time, and some of you may know this, the moms may tell you this, we have a high-risk cardiac coordination with I think all the hospitals in the city, and they will special deliver those babies with a pediatric cardiologist there if we know ahead of time. But sometimes we don't know ahead of time. Guess what age group most of these kids show up, about 90%? Under 28 days of age. Yes, and the majority of them show up in the first week. How do they show up? They turn blue. It's not a subtle presentation. That's called cyanotic congenital heart disease. How do you know it's their heart and not their lungs? We've got a fancy name for everything because we like fancy names. So hyperoxia test is our fancy name for child's blue. We put 100% oxygen on them. What color do they stay? Blue. If you put 100% oxygen on a kid and they still stay blue, it's probably not their lungs, it's their heart. And those kids, we need to get to a cardiologist as soon as possible because we don't want to compromise oxygen delivery to the blood, to the brain, and the rest of the vital organs. So those are usually very quickly managed by us with getting them to a cardiologist, and then they get capped, they get ballooned, whatever the child needs, we do. Acyanotic heart disease, these can be tricky. And I had a dear friend call me, and it was his third child, and he called and he said, Ann, I'm really worried. My wife has been trying to breastfeed, and she breastfed the second child, I swear, till 2.5. You know what I mean? She's like this super incredible mom. The baby won't breastfeed. The baby won't feed. Baby gets sweaty, gets clammy, can't eat. What is that? That's baby angina. What is the most stressful thing in the world babies do? They don't get on stress. They don't get on the little treadmills and run and do all that kind of stuff. They eat. That's their life stressor. So if it takes a baby a long time to feed and they start sweating, that's baby angina. So it is very important that all of those kids get brought as quickly as possible to a hospital so we can figure out how big the heart is, where the lesion is, and kind of get those things managed. And again, these are our kids under 28 days of age. Endocrine transition and metabolic abnormalities. Again, this is something that we commonly will see, especially in children that are born either at home and maybe somebody doesn't know about some of the specific things to look for, so the child has an underlying genetic metabolic abnormality, or these are kids that surprise us because every now and then we'll have a mutation. The saddest thing for us is sometimes these will be sudden death. And one of the kids that I saw that was a full arrest that unfortunately you guys got there and the kid had been down was a mom who'd been feeding her child every 2 hours. And she'd been going and she fell asleep on the couch and went 4 hours between feeds. And when she woke up, the child was not breathing, was in full arrest. The medics got there, did a glucose, it was under 10, or it was too low to detect, you know what I mean? They couldn't get anything. They pushed all the glucose they could, but it was too late. And we ended up losing that child. On autopsy, the child had a genetic inability to metabolize a certain thing called galactose, and so we could tell the mom, this is what we need you to do for future pregnancies. We're going to check future kids. Unfortunately, those usually show up in the first few weeks of life also. And we are very careful. If the kid's fussy, not acting right, sleepy, lethargic, not seeming to wake up right for feeds, this is the first test we do is the electrolytes, or is the glucose. Now, if you look at this one picture here, you can see this is a baby's genitalia, which I know that none of you are going to look at, but as physicians, we find it critical that it's part of what we look at. There are certain children that can be born with metabolic abnormalities where they don't produce things by their adrenal gland. It's called congenital adrenal hyperplasia. And usually those kids present in the first 2 weeks of life with hypoglycemia and messed up electrolytes. And by messed up electrolytes, I mean sodiums of 110 and potassiums that are very, very high. So when we do this exam, if we see this is not normal, then we do those tests immediately. Sometimes, though, it can be very subtle, the differences, especially in girls. And so sometimes what we'll do is if we have a low blood sugar, this is one of the things we check to make sure that the baby doesn't have that problem. Structural abnormalities. Some of the things that we have that are genetic can show up in that first month of life. Has anybody ever seen hydrocephalus in a baby? Hydrocephalus in babies is really easy to tell because the sutures are split. So the sutures don't grow together. If there's pressure inside the brain, what do? They grow apart. That's why we have open fontanelles, is because those sutures do not grow together. They're open, so the skull can grow apart. So usually babies with hydrocephalus will show up with rapidly growing heads, and their fontanelles will be full. So when you touch the top of their head, there will be a bulge instead of it being flat. And in those situations, we need to see them because we need to get the pressure off the brain to make sure that the normal brain tissue has a place to develop. GI things that can present in the first 28 days of life. Does anybody know what this genetic syndrome is? That's Down syndrome, correct? Down syndrome is associated with a certain type of abnormality where the duodenum will not develop correctly. They can get duodenal atresia or duodenal strictures, in which case then they show up with vomiting, and that kind of thing needs a surgical correction. So apnea. What is apnea? So have any of you been called to transport the baby that stopped breathing and turned blue? Or 100 times in 1 week? And I will tell you, we get as excited as you do in the emergency department because it's a huge sorting process. First of all, what we do is define what apnea is. If mom says the child actually turned blue around the mouth, there's a color change, that's significant. If mom says the child stopped breathing but was rosy and pink, then there's something called periodic breathing that we can see in the newborn period. But to be honest with you, it's not your job to tell them apart, and it's not my job as an emergency medicine doctor to tell them apart either. Usually what we do is we go through and we try and get a history to figure out what could be causing the apnea. What could cause apnea in a baby? Seizures. Has anybody seen a seizure in a 1-month-old or a 3-week-old? They can be very difficult. If they're tonic-clonic, jerking everywhere, it's easy to tell they're having a seizure. But what some of the babies will do is what we call the sword position, where their arm will go out, their leg will go out, and they lip smack. So their eyes will deviate to one side, and they go, and you'll have these very subtle changes that maybe only the parents will notice. The problem is if they're going apneic during that, what does it tell you? They've got a lack of oxygen to the brain. So it's critical that we see those kids and treat those seizures so don't we cause any further damage. Bronchiolitis, everybody know what RSV is? Everybody have a rough winter like I had a rough winter from, what did it start, like November, December, and it still hasn't gone? They told me the cultures haven't stopped yet. RSV is a virus that causes colds in adults and makes you miserable and unhappy, but it does not stop your breathing like it does in my babies under 28 days of age. So this cold virus also affects the brain, and it makes them have these periods where they stop breathing and they turn blue. And unfortunately, it can be very quick and very, very scary. So we have had numerous kids brought in, they get put in a room, the kids screaming bloody murder because everybody took all their clothes off and we're assessing them. Then all of a sudden everybody says, let's wrap them all up and let them rest for a minute. And all of a sudden the pulse ox goes off as their oxygen saturation drops, then their heart rate starts dropping, and that's a true apneic event. Also, you can see apnea from aspiration. This is more with kids that are early special needs kids. So some of our kids that are born with neuromuscular diseases, muscular diseases, may show up with vomiting that's going down the wrong pipe, and those kids can turn blue when the fluid goes the wrong way and blocks their trachea. So it's really important that these kids all be seen. Yeah, let's see if this is going to go forward. All right, so have I convinced you? What are we going to do with kids under 28 days of age? We're going to bring them in. We're just not going to even lose sleep over those kids. The other thing I'm going to mention, because this is really important, is when a child was born at 34 weeks and they are 6 weeks old, are they under 28 days of age? Yes, they are. So our preemies get even more special treatment. So if you're born at 32 weeks and you go home at 8 weeks of age, you're really only full term at that point in time. We treat them special up until they're 28 days because we know that there can be an extra long transition for the children that are born premature. And to be honest with you, I'd rather see them and tell them there's nothing wrong than have anything go wrong at home for them. Okay, benign symptoms. How many of you would say that, pretty much 80% of the pediatric world vomits? Maybe 90%. Maybe 95%. I swear, the kids vomit very, very easily, so it's a very common problem that we'll see in children. Runny nose, pretty benign. Head injury with no loss of consciousness and acting normally. That sounds pretty benign. That sounds like that should be okay. Unless you're vomiting and you have a ventriculoperitoneal shunt. Why do we put ventriculoperitoneal shunts in kids? And believe it or not, I had a 17-year-old that we had some medics leave this child at the scene. His mom called because he's 180 pounds, and she was trying to get him to the car, and he was vomiting so badly that she couldn't control. She was just a small lady, and she couldn't move him. And they got there, and they said, no, he's acting like he's drunk. You know, you need to get him to the hospital yourself. So this mom tried to carry this child into the car, which she somehow managed to do. I think it was just extra epinephrine. And then drove like a bat out of hell to get down to the hospital. His tubing runs from in here all the way down the side of his neck. This is where we drain the ventricles. There's usually a little palpable ridge here. So if you've ever got a question, run your hand up and down the sides of their head. It's not subtle. It sticks out. Usually their hair will cover it, but you can feel it. If they have one of those and they've got an altered mental status or they're vomiting, it's a serious problem. Tube runs down to their belly. What happens if this breaks? What happens if it gets blocked? What happens to their pressure in their brain? Goes off the wall, and they get sick fast. This child showed up and had a GCS of 10 by the time he got to us. We had already called, mom had called in, and so we called the neurosurgeon and said, can you just come down here? This kid doesn't sound right. The neurosurgeon had a needle in the kid's head in under 20 minutes. And the kid actually, the needle went in, fluid started coming out. He woke up and looked at his mom and said, my head hurts so bad, which I think were the happiest words this mother has ever heard in her entire life. Vomiting can be a sign of a metabolic disorder, and so it's really important, especially if the vomiting seems to be progressive or it's in our babies under 6 months of age, that we take a look at those kids. Sometimes that's a new metabolic disorder. The reason they're throwing up is their sugars aren't right or their electrolytes aren't right, and that makes them throw up, in contrast to the reverse where you vomit until you get the electrolyte abnormalities. I'm sure none of you have had kids with GJ tubes. All of you have seen our kids with GJ tubes, haven't you? These are tubes that we stick in to feed the children, and we can have one of two types. The G tube just goes into the stomach. The J tube gets fed past the stomach into the jejunum to increase absorption. And the other reason we use the J tubes is because if it bypasses the part where the stomach ends, the kids can't throw up. So a lot of times, if the kid's having reflux problems, it's a safer place to put the tube so that the feed goes definitely into their system. What can happen if a kid like that's vomiting? Could be obstructed, could be a blockage in the system, or it could be, especially in the older age groups, as my favorite is, they wrap their fingers around and start tugging on these things, and they can move them. What about bilious emesis? What is bilious emesis? Does anybody know? Green vomit, not yellow vomit. Yellow's the stomach, green's bilious. What does green vomit mean in babies? It means there's a blockage below the level of the stomach. So from our standpoint, bilious emesis in a child under 6 months of age is a medical emergency. So these kids all are very quickly seen. They get IVs started, and they get fluids. We put them NPO, and we get x-rays, and we do dye. Because what can happen, and I tried to find a picture of this, is that inside mom, the baby's intestines may have been born on the wrong side, or they may have been born so they're not attached to the wall. So what happens when the baby comes out is they twist. And if they twist, what happens to the blood flow to the intestines? Bad. It goes down. So the longer it takes us to get to the OR, the more intestine they're going to lose. So we have to diagnose the Malrose with the volvulus because those kids need to go very quickly to the operating room. Runny nose. One of my favorite chief complaints. If they ever tell you the nose is only running on one side, but their child would never stick anything in their nose, go ahead and look just to humor them and humor me. Because statistically, if it's a unilateral, there's something up there. I remember coming home late from night one work. I was working evening shift, and I was supposed to get off at 1, and I got home at like 3:30. And I was so tired, and I went to kiss my youngest son goodnight, and I looked over, and there was this thing hanging from his nose. And I was like, you know, anyways. So, being the good mother that I am, I quickly pushed down on the other side, blew really quickly, and popped the sucker out before he even woke up. Because I was like, we are not going down to my department for another 4 hours. I just can't take it. Other things that this can be is basilar skull fractures. I wish I could tell you in this day and age that no one ever hits their children and that no one ever has a boyfriend that hurts their children, or that when you leave them with a babysitter, they're safe. How many of you transported child abuse cases? It's our highest rate of mortality at Children's at this point in time. I think we had 12 deaths in November and like 10 in December, and it's just very, very sad. A while ago, I had a child show up in full arrest, and you know, it's so sad. You know, I'm starting my process, and I walked out to talk to the mom, and the mom looked at me and she goes, I don't understand how this could have happened. He was perfectly fine. I left him a half an hour ago with my boyfriend, and I went to the store. Well, I guess that's a level 1 trauma alert. We'll just be moving to the trauma bay. Subdurals, cerebral edema, 6 broken ribs, grade 3 spleen lack, grade 3 liver lack. So anytime you get called with a question, make sure you think of basilar skull fractures. Look for bruises in different stages of healing. If the child is looking at you and cute, it's your chance to make a difference in the kid's life, because the next hit may be the fatal one. And so it's really important that if you have any concerns, you think maybe this fluid isn't normal, you see a bruise back here, you see something that isn't right, just bring them down. We'll make sure that they're okay, and then they can go from there. Head injury with no loss of consciousness and acting normal. This is a very interesting problem for us. Have any of you got kids with hemophilia in your transport service areas? We have a huge, huge, huge Amish population with a large population of hemophiliacs that we follow at Children's. If a hemophiliac has less than 1% or less than 5% activity and hits their head, do you know what they have at home? Factor. Do you know what the parent's told to do? Push the factor before you call 911. Because what's the problem? With their low factor levels, what do? They bleed. They bleed really easily. A nosebleed can kill them. But think about they've hit their head and they don't stop bleeding. What can that do to a bleed inside the head? Very, very bad. So in general, kids with hemophilia or any of those type of classifications, we've got factor 8, factor 9 deficiencies, they should have already given the factor before you get there. The key is not to ignore the parents. If the parents say, my child has hemophilia, please just bring them down. Mom usually will carry the factor. Some of our parents aren't that good, so we'll get factor ready and push it. But they get factor before they even go to CAT scan for us, because we want to make sure we stop any bleeding, and that if there is an injury, we get the bleeding under control as fast as possible. There was a car accident a couple of years ago where the mom was dead at the scene and the dad was unresponsive, and I think he went to Grant. And the child was transported to us and had an intracranial bleed. And we were so blessed because the aunt came running in and the child had hemophilia. And so that would have been a very bad operation for our surgeon, although we were waiting on the PTT results. So we immediately started pushing factor on the child, and the child did very, very well, because then the bleeding would stop. Other things that will stop, that have a hard time stop bleeding, are von Willebrand's and platelet disorders. So it's really important if the child says, the parent says they've got any kind of bleeding disorders, that if they've hit their head, even if they're fine, just bring them down so we can see where their bleeding times are to make sure we correct it so that they don't keep bleeding. The golden rule of shunts: if you fall, where will you land if you have a shunt in your head? Right on the valve. It is a universal childhood rule that if you fall and there's anything that you don't want to hit, you will hit it first. And what can happen if you hit the valve? It can disconnect. Usually those kids are not sick. And what we do is just plain films, and we see if it's connected or it's not connected. If it's not connected, we're going to get it fixed before it's a problem. And so we like to see all of those kids also. Benign unless someone lies. And yes, I will tell you right here and now, boys with guns and pregnant girls will all lie to you. And that's been my universal kind of experience. We had a child that was shot with a BB by his brother. Do you think he told the paramedics the truth? No. He says, I was in the tree 7 miles away. I accidentally shot. I didn't mean to hit my brother. Did I mean to hit you? No, no, no. So the child, they left the child, little mark right here on his forehead. came in an hour and a half later with his mom because he was vomiting and not acting right and having some off balance. He missed his brain stem by 2 millimeters, and actually what they were practicing was something they'd seen on TV. So the brother had actually put the gun up against his brother's head and discharged it. The BB will go through the skull if you do that. And so it's really important. We've had BBs into the abdomen. So don't believe them. Whatever they did, move them 12 feet closer, put a little more PSI behind it, and assume that they have done a little bit more damage so we can make sure, because we had a kid in the urgent care that had also penetrated his peritoneum with a BB. Pregnant, assume anyone who has any breast development is pregnant until proven otherwise. And I do not mean that negatively. All you need is a negative test. But the problem is teenage pregnancy has so many complications associated with it that we can't afford to miss it. So a 12-year-old, and that was my youngest, who says that she's never had sex, she doesn't like boys until the ultrasound shows the ectopic pregnancy, it's not a good combination. And if they rupture, they can be fatal. And we have had children die from ectopic pregnancies. So make the assumption, think about it. I always tell them it's nothing personal. I screen everybody. You're negative, you're positive. I at least know what I'm dealing with, and I can make sure you're safe and that you have the best chance of survival. My last one was a girl that was about this far along who came in, and you know, she's with both of her parents having terrible abdominal pain, and the mom and dad are like, she can't be pregnant, and I just lifted up her belly, and the dad looked at me and goes, I think we're gonna step outside right now. And I'm like, that's fine, give me 5 minutes and I'll have her to Grand Hospital. We're gonna move this one very quickly. New diagnosis. One of the most interesting patients, and by the way, you know the medical school, probably this is a paramedic rule also, you never want to be an interesting patient. That's a really bad thing to be. But I had an interesting 8-month-old that came in with 2 Somali parents who did not speak any English. And their complaint was the child fell 8 days ago. They had gone back to their doctor. It wouldn't stop bleeding. And it was a laceration just like this. And it would not stop bleeding. Mom said she'd been holding direct pressure 5 to 7 times a day. This was all through an interpreter for me because they really didn't speak much English. So she kept telling me all this stuff. And she went then to another clinic, and they told her to use more direct pressure. She went then to, I can't remember, she went to like 5 places and couldn't stop the bleeding. So I told her, I said, you know what, is there anything in your family history you want to tell me? And the interpreter asks her this, and she said, I have 3 brothers who need special medicine before they get operated on because they're bleeders. Well, that would have been helpful information probably for that first doctor that first day. Those are genetic. So if there's bleeders in a family, it goes men to boys. So mom was a carrier, took it from her brothers to the child. He was a new hemophiliac. And actually, it took Hemocon in the emergency department for us to stop his bleeding, and his hemoglobin was 6. So obviously, mom was correct. He had been having significant bleeding. But don't ignore the parents. If they tell you something is significant, they can't stop it, just bring them on in and we'll take a look and make sure that there isn't some underlying problem. This is a rash called a petechial rash. And these kids have very low platelets. It's post-viral, it's a benign thing, unless you bleed into your brain. So if you see this rash, which is these little red dots, and a child that's hit their head and they're acting or vomiting, they need to come in so that we can take a look and make sure they don't have this bleeding problem. Pre-existing conditions that are a problem, hypoglycemic. Kids that have any problems with hypoglycemia are huge problems for us. And one of the groups I want to mention, you know how I talked about the GJ tubes? What do we use them for? Feeding, right? So we start feeds. If I'm giving you continuous 24-hour feeds, are you getting glucose 24 hours a day? And if I'm giving it to you because say you weigh 4 or 5 kilos and I'd like you to be up to 9 or 10 kilos, and then all of a sudden I turn it off, what could happen to you? What would happen to your glucose if I suddenly turn off a 24-hour glucose strip? You've suppressed the insulin in that child's body by doing that. So the biggest problem is if the GJ tube isn't working and they get continuous feeds, We can deal with the GJ tube later. You need to check their glucose, make sure their glucose is okay, and if their glucose is not okay, treat it. We'll take care of the rest with getting the line reestablished. Carnitine deficiencies, metabolic abnormalities, again, listen to the parents. I had a resident come out and he said to me, he goes, "Ann, this kid's thrown up 4 times, the kid looks great, parents are nuts. I just want to send him home." And I said, "Does the kid have any medical problems?" And he goes, "Yeah, something called carnitine deficiency." And I'm like, "Well, did you call the metabolic specialist and find out if there's a protocol that we follow for these kids, because they can get low sugars?" He's like, "Oh, I'll go call them." These kids are special. So when they get sick, we actually put an IV in them, give them carnitine IV because they can't swallow their medicine, and we hydrate them up. So if parents can name a disease you've never heard of, they just need to come down and see us. We may never have heard of it either and have to look it up. Electrolyte abnormalities, anybody who has congenital adrenal hyperplasia, we have numerous families out in the community. It's called congenital adrenal hyperplasia, commonly called CAH. If you have any of those kids, the parents will be standing there with a steroid syringe begging you to push it. The kids can't make steroids on their own, so when they get stressed, they need stress doses. You just need to know if they give that name, you need to bring them to us. Any kind of hardware that is dysfunctional or seems to be a problem, those kind of kids clearly are going to need to be evaluated by us. I went through that. Pre-existing conditions I'll also mention are sickle cell disease. There's 3 different types of crises. I don't even talk about pain crisis. Do any of you ignore a screaming child who says his leg hurts? No. So if you get sickle cell disease and you're screaming and you're in pain, you guys clearly are going to bring those down. But there's a couple other things these kids can do that can be very bad that I need you to know about. Sickle cell disease kids are more prone to infection because they have sickle cells. Those are the sickle cells. So they get stuck places. So they're more prone to infection. So if they have a fever and sickle cell, they need to come see me. And they'll get antibiotics within an hour of showing up with us. You also need to know that sometimes sickle cells can get stuck in bad places. So if they get stuck in the spleen, what can happen to the spleen? Boom, boom, boom. Grows bigger and bigger and bigger. What happens if it gets too big? Ruptures. So it's really important if the mom says the kid looks pale, they're sweaty, they're clammy, and they've got sickle cell disease, that they get brought to us so we can look at them very carefully. I don't think I need to tell you much about the congenital heart disease kids. The only thing I'm going to warn you about is that kids with congenital heart disease that have any kind of spells, please do not use your routine protocols. So if I've got a 17-year-old that's a partially corrected transpo who's been to Pittsburgh twice and been to Columbus Nationwide Children's, twice, and has had all these different surgeries, do not routinely give them nitro. Call, because depending on what the structure is and how we've revised things, nitro might be bad. We try to make sure the families know those things, but in general, we would prefer that the less we do until we can evaluate them, because we're going to be comparing what their baseline is to what they've done. So as long as their vital signs are stable, we'd prefer to see those kids. Okay, so I'm just going to make sure that you are very carefully listening to these parents. They are incredible people that take care of these just lovely children. But they're the only ones who can tell sometimes when something's wrong. So if mom says the oxygen requirement's increasing and we're not sure why, usually they have home health care nursing. Make sure that those kids get down to us. Cardiovascular. One other thing I wanted to mention is if mom says the kid's not breathing right and you get there and the pulse ox is 100%, but she says the kid has Duchenne's muscular dystrophy, what can be the problem with that? What happens with the neuromuscular? Do they have lower oxygen requirements, or do their muscles tire out? Muscles tire out. What changes when your muscles tire out? Your PCO2, your oxygen levels do not tire out. So we had one child that the mom said the kid wasn't breathing right, and if you looked at the kid, he was breathing 12 times a minute, which should be just lovely, until you got his blood gas with a pH of 6.9 and a PCO2 of 104. That's a problem. But he was tiring out. He couldn't show the signs of respiratory distress. So for those special needs, neuromuscular, muscular disease kids, understand they can't get into respiratory distress, so we have to be extra careful with them. You will see a lot of special needs kids with seizure disorders. Parents are the only ones that can recognize the seizures. If the family wants to come down to us and be seen, have them come down. We have a fabulous neurology department now, and so usually they've spoken to them. If you do not know what drug to use and the family is at a loss, just encode us. We come very quickly to the phone and we'll help talk you through it. Usually it's not going to be easy like a nasal Versed dose or, a rectal diazepam. In fact, I had one of them ask me, okay, mom's already given 3 rectal diazepams at home. What do I go to next? And that's a very fair question because you don't want to stop the breathing. So those kind of things, call us and we'll help you talk through them. Last one I'm going to do is anaphylaxis. We have a lot of kids who are out there with EpiPens. If the child gets an EpiPen, gets a dose of diphenhydramine, and is better, please do not leave them. Please bring them to me. If you swallow peanuts and you're allergic to peanuts and get an epinephrine, will you get better? Yes, your hives will go, your respiratory will get better. What's the problem with peanuts in your stomach? Are they gone? No. Will they keep getting absorbed? Yes. For how long? 6 to 8 hours. We bring them all in. They get to stay with us, and a significant number of them will get repeat epidoses. We will also start steroids as soon as they show up, but we still have to watch them until we're sure everything's out of their stomach and they can't get any more allergy substances into their bloodstream. All right. There you go. Who should I call first, 911 or technical support? Thank you very much.